In this next section, we will be going over several questions having to do with autonomic pharmacology. I'll talk you through these questions and follow along on the slides as we go. Okay. Now we'll go over a few cases and questions that you'll likely to see on the USMLE Step 1. For question number 1, we will analyze blood pressure and heart rate after certain medications are given to patients. An anesthetized subject is given an IV bolus dose of a drug called drug 1, while blood pressure and heart rate are recorded on the left side of the graph. And then the patient was given drug 1 again, but before that he was pre-treated with drug 2, as shown on the right side of the graph. It's up to you to determine what drug 1 and drug 2 are. As you can see, drug 1, which is not labeled, raises systolic blood pressure and diastolic blood pressure, as well as decreasing heart rate. Over here, on the right side of the graph, we can see that drug 2, if pre-treated, will completely abolish the signaling of drug 1. This question is sort of testing your ability to identify what these medications are and to determine which inhibitor is being used to block its effect. These questions are very typical of the medical licensing examination. So the question is, what are drugs 1 and 2? So in order to think through this clearly, you'd have to ask yourself which medications would be likely to increase systolic and diastolic blood pressure. With regard to the alpha activity, this would have to be an alpha-1 agonist. With regard to heart rate, the beta activity would have to be marginal at best. Because if beta-1 were activated, you'd see an increase in heart rate. But actually, we don't see that increase in heart rate. And if beta-2 activity were high, we would actually see a decrease in the diastolic pressure. But what we see here is an increase in diastolic blood pressure. Drug 1, therefore, is phenylephrine, which is a commonly given alpha-1 specific receptor agonist. As for what drug 2 is, it would have to be a blocker of the alpha signaling, because all phenylephrine is an alpha-1 agonist. Therefore, any drug that would block alpha signaling would block the response to phenylephrine. Question 2 is a question similar to question 1, except it's more complicated. A patient is administered medications A and B alone on the left, and then is pre-treated with inhibitors C and D prior to receiving medications A and B. Blood pressure, heart rate, and systemic vascular resistance are measured. It's up to you to identify the drugs. As you can see, when this subject is given drug letter A, the patient exhibits increases in systolic blood pressure and diastolic blood pressure. It sees an initial increase in heart rate, which is then decreased, and an increase in systemic vascular resistance. This increase in systolic and diastolic blood pressure is most likely related to alpha-1, as well as the increase in systemic vascular resistance. This initial increase in heart rate right here is most likely related to beta-1 activity. This following decrease in heart rate is most likely related to a vagal response that is related to the increased blood pressure and the body's ability to compensate for that. As you can see in the next diagram, when the patient is pre-treated with inhibitor C, the alpha response, the alpha-1 response, is blocked. What you see here is a beta-1 response and a beta-2 response. The beta-2 being vasodilation of skeletal muscle vascular beds, and beta-1 being an increase in heart rate. This beta-2 response is responsible for the decrease in systemic vascular resistance because you've dilated the smooth muscle of the skeletal muscle beds. So drug C would have to be an alpha blocker. When pre-treating with drug D, drug A still has its alpha-1 signaling, as you can see here. However, it does not have that little bump in heart rate. Drug B, as you can see, has a different profile. It increases the systolic blood pressure, which is most likely related to alpha 1. It, however, decreases the diastolic blood pressure, which is most likely related to beta 2. It also increases heart rate, which is most likely related to beta 1. It has a slight increase in systemic vascular resistance that's most likely related to a combination of alpha 1 and beta 2 activity. When drug C, the inhibitor, is given, as we know from the previous slide, C is most likely an alpha blocker. And we can see that alpha 1 signaling is blocked, but we still see the beta 2 signaling. And we still see the beta 1 activity here that drug B causes. With regard to drug D, which we think may be a beta blocker because it blocked alpha's effect to increase the heart rate, we can see that the alpha 1 signaling is still here, but the beta 1 signaling is blocked. Therefore, drug D might be a beta blocker. And we can see also that drug D has blocked this slight decrease in diastolic blood pressure from the beta 2 signaling. So therefore, drug D is most likely a beta blocker if it's given before drug B. So drug A, we said, has alpha 1 activity, right? It has beta 1 activity. Okay? It has slight beta 2 activity. And it has beta 1 activity. Drug A is norepinephrine. And we see this mostly because norepinephrine will raise both systolic and diastolic blood pressure. And its alpha effects are stronger than its beta 1 effects. Remember, potent activity at alpha receptors and beta 1 receptors, but very little activity at beta 2 receptors. Drug B is epinephrine. And drug B affects alpha, beta 1, and beta 2 all relatively strongly. It affects beta 1 most strongly. And it has prominent actions on the heart and the vascular smooth muscle. Drug C, as we talked about, is an alpha blocker, phentolamine. Remember, epinephrine plus an alpha blocker causes epinephrine reversal. And norepinephrine plus an alpha blocker will block the pressor effects of norepinephrine, which reveals the beta 1 effects. Drug D, as we talked about, is a nonspecific beta blocker, or propranolol. Remember, epinephrine plus a beta blocker will cause a prominent vasoconstrictive effect, whereas norepinephrine plus a beta blocker will cause the same problem, prominent vasoconstrictive effect. Question number 3. The increase in heart rate and cardiac contraction normally induced by electrical stimulation of sympathetic nerves can be blocked by which of the following? As we know, sympathetic nerves usually release epinephrine and norepinephrine, and these can bind to alpha receptors and beta receptors. Which of these receptors is most likely causing increase in heart rate and increased inotropy? That would be the beta receptor. The beta receptor is responsible for the heart effects. And which of the following medications is most likely to cause this? A beta blocker, also known as propranolol. Question number 4. A drug that blocks the heart rate effect of a slow IV infusion of phenylephrine is A. Atropine, B. haloperidol, C. physostigmine, D. pilocarpine, E. propranolol. Phenylephrine, as you know from the previous questions, is an alpha agonist and works by stimulating alpha 1, which increases blood pressure. This increased blood pressure has what effect on heart rate, though? It decreases heart rate. So which of these medications would actually block this and allow the heart rate to come back up? The answer is atropine. We often give atropine to raise heart rate in a patient with bradycardia. Remember that the way phenylephrine will lower heart rate is through the vagus nerve, or cranial nerve 10. Atropine will block that. Question number 5. Infusion of phentolamine into the CSF of an experimental animal will block the blood pressure lowering action of which of the following drugs? A. Clonidine, B. Enalapril, C. Guanethidine, D. Reserpine, E. Trimethophan. When you think of CSF, cerebrospinal fluid, you should think of the central nervous system. And you'd want to know which of these molecules are most active in the central nervous system. As you know, clonidine is. So is guanethidine and reserpine. Trimethophan works in the ganglion. And enalapril is an ACE inhibitor, so it's not very active in the central nervous system. What is phentolamine? Phentolamine is an alpha-1 and an alpha-2 blocker. Normally, when it's given intravenously, it does not cross into the CSF. However, if it's given in the question into the CSF, it will block alpha-2. And which of these molecules is an alpha-2 agonist? That would be clonidine. Therefore, phentolamine would block the blood pressure lowering effect of clonidine. Question number 6. The pharmacokinetic characteristics of several hydantoin derivatives, each with anticonvulsant activity equal to phenytoin, are examined in phase 1 trials. The rationale was to identify a drug with more desirable kinetic properties than those of phenytoin. Which of the following drugs has the optimal pharmacokinetic properties for oral use in the management of seizures with F equaling bioavailability? This is a question that tests your ability to understand what are the desirable properties for controlling seizures. If this medication is to be given orally, what would you like the bioavailability to be? Would you like it to be high, or would you like it to be low? More effective drugs, drugs that work quickly, have a higher bioavailability. Therefore, you would not want a medication with a 10% bioavailability. You'd like 90% or 85%, 95%. So we can rule out answer number A. In terms of plasma protein binding, as we talked about before, drugs that are very highly plasma protein bound work more slowly. And therefore, you would want a drug that has a very low plasma protein binding. So answer number C is pretty much out. In terms of kinetics, we talked about which medications are more easily dosed, and we mentioned that drugs that are first order generally are easier to dose because they're easier to keep in the therapeutic range. Therefore, you would not want the zero order medication. And then, which medications are easier to work with? Those that do induce cytochrome P450 systems, or those that do not? In general, if they do not induce cytochrome P450, they're easier to work with. And therefore, we can rule out the ones that do induce cytochrome P450. So the best drug here is D. And the reason is that it's got a high bioavailability, it's low plasma protein binding, it's first order kinetics, which makes it easy to dose, and it does not induce cytochrome P450, which makes dosing with multiple medications more complicated. Therefore, this medication is able to give. Therefore, you're able to give this medication with other drugs, and you don't have to worry about its induction of cytochrome P450. Question number 7. A patient on digoxin therapy has developed toxicity. The plasma digoxin level is 4 nanograms per mil. Renal function is normal, and the plasma half-life for digoxin in this patient is 1.6 days. How long would you withhold digoxin to reach the safer level of 1 nanogram per mil? Currently, the patient's level is 4 nanograms per mil. How many half-lives is it going to take to reach 1? it would take the patient one half-life to go from 4 to 2. That would be 1.6 days, as it said here. It would take another 1.6 days to go from 2 to 1. Therefore, 1.6 plus 1.6 is equal to 3.2. And the answer is 3.2. Question number 8. Patient is admitted to the hospital for pneumonia because of Pseudomonas aeruginosa. The antibiotic ciprofloxacin is ordered. The clearance and the volume of distribution of Cipro are 80 mils per minute and 40 liters, respectively. If you wish to give a loading dose to achieve the therapeutic plasma concentration of 4 milligrams per liter rapidly, how much should be given? So this is a loading dose question. You know the clearance of the drug. They give it to you. It's 80. And you know the volume of distribution. That's 40 liters. The loading dose is equal to the volume of distribution times the desired plasma protein concentration. The volume of distribution is 40, and the desired plasma protein concentration is 4. Or desired plasma concentration is 4. Watch out for your units. You get 40 times 4 equals 160 milligrams. They give you the clearance, but you didn't need it to answer this question. Question number 9 is the same question. However, instead of giving the drug intravenously, we're going to give the drug orally. And they tell us that the bioavailability of this drug is 0.5. This means that the drug is only half as powerful when given by mouth as it is by given intravenously. Therefore, thinking intuitively, we'd have to take that 160 milligrams that we achieved by multiplying the volume of distribution times the desired plasma concentration and divide it by 0.5, which is actually like multiplying by 2. So we'd have to give twice as much medication if we were going to give it PO, or by mouth, as if we were going to give it intravenously, because the bioavailability is only half. So the answer is 320. Question number 10. Patient was admitted to the emergency room 2 hours after taking an overdose of phenobarbital. The plasma level at the time of admission is 100. And the apparent volume of distribution, the half-life, and the clearance of phenobarb are 35, 4 days, and 6.1 liters per day, respectively. The question is, how much was ingested? So this is actually a loading dose question. The clearance and the half-life are not needed. To calculate the loading dose, you change the equation to equal loading dose equals plasma concentration times the volume of distribution. The important thing to remember is 2 hours after the patient goes to the emergency room are negligible compared to a half-life of 4 days. So therefore, you can use CP as that 2-hour time point and estimate. As long as you have the plasma concentration when they arrive at the hospital 2 hours after taking the overdose. And you can guesstimate that they took approximately 3.5 grams of phenobarbital. Question number 11. You wish to administer gentamicin for suspected gram-negative sepsis in a 55-year-old male. He weighs 110 kilograms and is 40 kilograms above his lean body weight. Your farm manual suggests that the dosing weight for gentamicin should be calculated with the following formula. Dosing weight equals lean body weight plus 1/4 times the obese weight. You find that the volume of distribution of gentamicin is 0.3 and the half-life is 2 hours. Based on this information, what would be the appropriate loading dose, assuming that you desire a plasma concentration of 7 milligrams per mil? So first we have to calculate the dosing weight. And that's equal to the lean body weight, which we have, 70 kilograms, plus 1/4 of the obese weight. We know that he is 110 kilograms and that he's 40 kilograms above his lean body weight. Therefore, his lean body weight is 70 kilograms. The obese body weight is 40 kilograms. So 1/4 times the obese weight is 10. Therefore, 70 plus 10 equals 80. That's his dosing weight. This is how we are able to obtain the volume of distribution. 0.3 times 80 equals 24 liters. That's our volume of distribution. The loading dose equals the steady state concentration times the volume of distribution, which is equal to 7 times 24. It's important to remember that the units here are different. 7 micrograms per mil is actually equal to 7 milligrams per liter. You multiplied both units by 1,000. Times 24 liters is equal to 168 milligrams. So the approximate dose that you would give, so the approximate loading dose would be 168 milligrams. A patient is admitted to the hospital for pneumonia due to Pseudomonas aeruginosa. The antibiotic Cipro is ordered. The clearance and the volume distribution of Cipro are 80 mils per minute and 40 liters respectively. Which maintenance dose should be administered intravenously every 6 hours to eventually obtain a steady state concentration of 4 milligrams per liter? Remember that at steady state, the rate in has to equal the rate out. And remember that the rate out at the steady state is equal to the plasma concentration times the clearance. So the dosing rate is going to be equal to 4 milligrams per liter times 80 mils per minute, which are the clearance and the plasma concentration. Remember your units. It's important to convert milliliters to liters. 4 times 0.08 will give you 0.32 milligrams per minute. But the question asked about every 6 hours. So therefore, you have to multiply this times 6 for the hours and times 60 minutes per hour. That'll give you 115 milligrams every 6 hours. Question 13 is quite similar. Instead of giving the medication IV, we'll give the medication orally, and the bioavailability is 0.5 again. Which dose should be given? Again, it's the same answer, 115 milligrams, with the same calculations, but we must divide by 0.5 because the bioavailability is 0.5. Therefore, the answer is 230 milligrams. Because dividing by 0.5 is just like multiplying by 2. Question 14. Patient with an arrhythmia is to receive lidocaine by a constant IV infusion. The target plasma concentration is 3 milligrams per liter. The pharmacokinetic parameters for lidocaine in the general population are the volume of distribution of 70 liters, clearance of 35 liters per hour, and a half-life of 1.4 hours. The infusion is begun. The plasma concentration of lidocaine is measured 2.8 hours later, which is 2 half-lives, and is reported to be 1.5 milligrams per liter. This indicates that the final steady-state plasma concentration in this patient will be. This is sort of a tricky question, and it's meant to test your ability to remember that after 2 half-lives, it's generally understood that the current concentration would be 75% of the steady state. If after 2 half-lives, which 2.8 hours is, you are at 1.5 milligrams per liter, that is 75% of your steady state concentration. if 1.5 milligrams per liter is 75, then 2.0 is 100%. As you can see, 2.0 milligrams per liter is less than what your target was. And as you can see here in this chart, after 2 half-lives, the plasma concentration is 75% always of what your final plateau concentration will be. This is a general concept of half-lives that is something that you should memorize. No matter what the drug is, no matter what the half-life is, as long as there are first-order elimination kinetics, after 2 half-lives, if the drug is being continuously administered, the plasma concentration at that point, at 2 half-lives, will always be 75% of the maximum. So if this equals 1.5, then this equals 2. And this equals 1, and this equals 0.5. Okay. Question 15. For this data, calculate the volume of distribution, assuming that the loading dose is 200. This question is testing your ability to figure out what the C0 is. And as you know, all you have to do is extrapolate this curve back along the elimination phase, and that will tell you what your C0 is. Remember, C0 is a false number, and in this case, the C0 is 10. It's a hypothetical drug concentration as if distribution had been achieved instantly. So the volume of distribution is 200 divided by 10, which is equal to 20. Question 16. Most weak acid drugs, as well as weak base drugs, are absorbed primarily from the small intestine after oral administration because A, both types are more ionized in the small intestine, B, both types are less ionized in the small intestine, C, the blood flow is greater in the small intestine than in other parts of the gut, D, the surface area of the small intestine is greater than that of most other parts of the gut, and E, the small intestine has nonspecific carriers for most drugs. This is a question that's meant to test your knowledge that the small intestine is where most drugs are absorbed, simply because the surface area is greater. And that increases that organ's ability to absorb all medications. Question 17. The clearance of a drug is found to be unchanged whether the urine is acidified or alkalinized. This shows that the drug is A, a strong acid, B, a weak acid, C, a strong base, D, a weak base, or E, neither an acid or a base. If acidification and alkalinization don't affect the clearance, then most likely that drug is neither an acid nor a base. This is the end of the autonomic and general pharmacology questions section. The next section will involve toxicology.